Hi dear students, welcome to the class on antiplatelet drugs. Myself Dr. Padmanabha, TS, your pharmacology faculty. So at the end of this class, you should be able to classify antiplatelet drugs, explain the mechanism of action of antiplatelet drugs, explain the clinical indications associated with antiplatelet drugs, as well as the adverse effects and the contraindications for antiplatelet drugs. So these are the specific learning objectives you need to understand and you need to learn. So coming to the antiplatelet drugs. So here we have the classification of antiplatelet drugs. We have a thromboxane synthesis inhibitor, that is aspirin. We have a platelet cyclic AMP enhancer, we have diperidol. Then we have a P2Y12 receptor antagonist. Examples are ticlopidine, clopidogrel, prasugrel and ticagrelor. And we have a glycoprotein 2B3A inhibitors like apixaban, eptifibatide and tirofiban. And we have a newer drug, that is thrombin receptor inhibitor, that is orapaxar. So these are the antiplatelet drugs. One of the most commonly used antiplatelet drugs is the aspirin. And how do they act? So this antiplatelet agent will going to decrease or attenuate the platelet activation. So as you know that platelets are responsible for aggregation. So these drugs will going to decrease the platelet activation. So aspirin, clopidogrel, prasugrel, ticagrelor and orapaxar will decrease the platelet activation. On the other hand, glycoprotein 2B3A inhibitors will decrease the platelet aggregation property. So basically, most of the drugs will inhibit the activation, but glycoprotein 2B3A inhibitor will inhibit the aggregation of two platelets together. So this is how the platelet aggregation takes place, which involves the plaque disruption, which activates the collagen, leading to the platelet adhesion and secretion, which in turn leads to the activation of COX-1, which will activate the thromboxane A2 activity as well as the ADP, which finally leads to platelet recruitment and activation. On the other hand, even the von Willebrand factor and tissue factor will going to stimulate the thrombin, which finally von Willebrand factor as well as thrombin will help in platelet recruitment and activation, and followed by activation of the protein, that is the glycoprotein 2B3A, leads to platelet aggregation. So platelet will come together and the two platelet will combine and it forms a aggregation and it becomes a clot or the thrombus. So here what you need to remember is, let us understand the sites of the antiplatelet drug action. So aspirin will going to inhibit the COX enzyme, thereby it inhibits the platelet aggregation. How? Aspirin inhibit the thromboxane A2 activity, which is responsible for the platelet aggregation. So on the other hand, ticlopidine, clopidogrel, prasugrel, cangrelor and ticagrelor will inhibit the ADP activity, or it will inhibit the P2Y12 receptors. On the other hand, we have a apixaban, eptifibatide and tirofiban. Sorry for the spelling mistake, it is eptifibatide, which will going to inhibit the glycoprotein 2B3A receptors. So on the other hand, we also have a orapaxar. So orapaxar is the thrombin inhibitor. Let's move on to the individual drugs. So the mechanism of action in common is, all these drugs will going to decrease the platelet aggregation. So we learn about, let us see the mechanism of action of aspirin, clopidogrel, eptifibatide and the cilostazol. Aspirin irreversibly blocks the COX-1 enzyme, cyclooxygenase enzyme, thereby it decreases the thromboxane A2 release, which is responsible for platelet aggregation. So clopidogrel will going to block the ADP, that is P2Y12 receptors, thereby it decreases the, it will cause ADP induced decreased induction of expression of glycoprotein 2B3A. So basically by inhibiting the ADP receptors, the expression of GP2B3A will be reduced. So we have a prasugrel ticagrelor with the similar action, and eptifibatide will block the GP2B3A fibrinogen receptor, thereby it will going to inhibit the platelet aggregation. So it will inhibit the linking of one platelet with the another platelet. So fibrin is responsible for combining the platelets together with the help of the GP2B3A activity. So iptafibatide tirofabin has got similar mechanism. Silastazole will block the phosphodiesterase activity. Thereby it decreases cyclic AMP hydrolysis, thereby it decreases the cyclic AMP in the platelet, thereby it produces antiplatelet action. So coming to the individual drugs, so let us understand the thromboxane synthesis inhibitor. So under thromboxane synthesis inhibitor we have a aspirin. So aspirin, as you know, that it is one of the very important antiplatelet agent which is used commonly in day-to-day practice as an antiplatelet agent. So as you know that thromboxane A2 is responsible for platelet aggregation. When the platelets are exposed to this aspirin, so where it is exposed? It is exposed in the portal circulation before deacetylation. So before deacetylation of the aspirin, so platelet will be exposed to aspirin in the portal circulation, and aspirin will going to acetylate the COX-1 as well as the thromboxane synthase enzyme irreversibly. So what is the mechanism of action of aspirin? Aspirin irreversibly blocks the COX-1 activity, thereby it decreases the thromboxane A2 synthesis or release from the platelet, thereby it producing the anti-aggregatory effect, and almost the action or the effect will remain for 5 to 7 days, almost a week. So thereby platelet cannot synthesize fresh enzyme for the period of 5 to 7 days. The reason being there is no nucleus which is present in the platelets. So because of this, what will happen is there is an increased risk of bleeding. So maximal inhibition will be seen at the dose of lower dose. Low dose aspirins are preferred. The low dose aspirin means the dose is ranging from 75 to 150 milligram per day or 75 to 325 milligram per day. So because of there is no platelets, there can be increased risk of prolonged bleeding. And the additional action associated with the aspirin is it inhibits the ADP release from the platelet, thereby it produces anti-aggregatory action. It also inhibits the COX-1 enzyme in the vessel, thereby it decreases the prostacyclin activity or release. Since the blood vessel, that is the intima, can synthesize the fresh enzyme, COX activity will be regained. So aspirin has got two major broad actions, that is it will going to inhibit the thromboxane A2 activity, thereby it inhibits platelet aggregation. On the other hand, there is also a protective vasodilatory action because of the blood vessel intima has a capacity to synthesize the fresh COX enzyme, thereby it will going to increase the prostacyclins which are responsible for anti-aggregatory action, and also it is responsible for vasodilation. So what are the uses of aspirin? So aspirin can be used in acute coronary syndrome, coronary stenting procedures during, and also to decrease the incidence or recurrence of thrombotic strokes. So what are the adverse effects expected out of aspirin? Since it belongs to non-steroidal anti-inflammatory agent, it can cause gastric ulcer, it can cause tinnitus, it can cause allergic reaction, it can cause renal injury as well as Ray's syndrome, especially if it is given in a children who is having a fever. So aspirin should be contraindicated or avoided in children less than 12 years of age. So next, coming on to the platelet cyclic AMP enhancer. So under this we have a diperidol. So diperidol is a vasodilator which is basically used in the angina, which also shows a coronary stale phenomenon. So what is the mechanism of action? basically it will going to increase the cyclic AMP. How? By inhibiting the phosphodiesterase enzyme, they increases the cyclic AMP levels and also blocks the adenosine uptake. So thereby it also potentiates the prostacyclin activity, thereby totally it has got the anti-aggregatory action. So it has got no action, or it will not produce any alteration with respect to the thromboxane A2 or prostacyclin I2 levels in the body. So what are the uses of diperidamole? It can be used in the prosthetic heart valve to reduce the thromboembolism as it improves the warfarin response. Warfarin is an anticoagulant. And also it can be used in transient ischemic attack to enhance the antiplatelet action by aspirin. So basically you can be used in case of the heart valves as well as transient ischemic attack to prevent the thrombus formation. So next, coming to the P2Y12 receptor antagonist, under this the prototype drug is the Clopidogrel, which is a potent congener of ticlopidin, which is also called as ADP or P2Y12 receptor antagonist. Basically what they do is, whenever this P2Y12 receptor gets activated, they inhibit the adenyl cyclase, thereby they decrease the cyclic AMP levels, which is required for anti-aggregatory property to remain. So what will happen is, since it is a G-coupled protein receptor, there is a GPCR mediated ADP induced platelet aggregation. So clopidogrel irreversibly block the ADP P2Y12 purinergic receptors, thereby it will decrease the ADP induced expression of GP2B as well as 3A receptors, thereby it decreases the ADP induced platelet aggregation. So basically finally leading to inhibition of the platelet aggregation. So pharmacokinetically, this is the prodrug. The clopidogrel, before getting activated, it is an inactive drug. So clopidogrel requires a CYP2C19 microsomal enzyme to get converted into the active form, and it's also slow acting, and action will take place around 4 hours. And whenever there is a CYP2C19 polymorphism in an individual, so in such individual you can have a decreased clopidogrel effect with respect to the antiplatelet action. So action will remain for 5 days, and whenever you give a omeprazole, which is a proton pump inhibitor, that is the PPIs, which are used in gastric ulcer. So omeprazole will going to inhibit the CYP2C19 activity, thereby what happens to the clopidogrel? If you combine together, clopidogrel action will not take place, clopidogrel efficacy will come down. So what are the uses of clopidogrel? It is used in acute coronary syndrome, in coronary stenting to decrease the incidence of thrombotic stroke. So what is the adverse effect? So although it is safe and better tolerated, always please remember the adverse effect which is associated with any of the antiplatelet drug will be a bleeding. And slightly it has got lower annual risk of primary ischemic event when compared to the aspirin, and it is very popularly used as a dual antiplatelet therapy along with the aspirin in case of unstable angina, in case of the non-ST segment elevated MI, which are tried through the CURE trial, and also there is a reduction in MI and stroke as well as cardiovascular death incidence with the use of the dual antiplatelet therapy, that is the aspirin along with the clopidogrel. And also it can be used to check restenosis in the stented coronaries. So why ticlopidin is not used now? Because of a lot of adverse reactions or the serious adverse effects like neutropenia, thrombocytopenia, hemolysis and the jaundice, mainly because of the neutropenia and thrombocytopenia. So coming to the prasugrel, which is a thienopyridine, the mechanism is similar to that of the clopidogrel. Basically, it is a newer, potent, faster acting, irreversible P2Y12 purinergic receptor blockers, which has got strong and rapid antiplatelet action. So prasugrel is a strongest antiplatelet action, and since it is a prodrug, again it is rapidly absorbed and gets activated fast, and it has got fast and more consistent platelet inhibitory action. So again it requires CYP2C19 similar to that of the clopidogrel for activation, but activation is very faster than the clopidogrel activation. The faster one-step process where response is not affected whenever the individual has got any CYP2C19 polymorphism, or along with the omeprazole also it doesn't it doesn't lose out its therapeutic efficacy. So when we compare the prasugrel and the clopidogrel, prasugrel is superior clinical outcome and reduction in the stent thrombosis has been observed, and also the 90% reduction in the death rate are observed with respect to the prasugrel when compared to the clopidogrel. So when we compare the recovery of platelet, prasugrel will take 7 days, whereas clopidogrel will take 5 days. And what are the indications of prasugrel? They are used in the ST segment elevated MI and also in case of acute coronary syndrome to cover the angioplasty. Again, the risk associated is the bleeding is the serious adverse effect which you can encounter, and where you need to be not using this prasugrel in case of ischemic stroke and transient ischemic attacks, as it increases the risk of intracranial bleeding or intracranial hemorrhage. Next, coming to the ticagrelor, which is a non-thienopyridine. Mechanism of action is it inhibits binding of ADP to P2Y12 receptors, thereby it inhibits the platelet aggregation. So ticagrelor is the latest drug among the ADP receptor inhibitor. It reversibly, so clopidogrel, prasugrel was blocking the P2Y12 receptors irreversibly, but ticagrelor it reversibly inhibits the P2Y12 receptor, thereby it inhibits the platelet aggregation. So it is faster, it is more potent, it is more consistent, and actions are faster in onset, quick offset of action also. Biological time of life is around 12 hours. The risk of cardiovascular mortality is reduced and when compared to the clopidogrel, ticagrelor, cardiovascular mortality risk is very less. And risk of intracranial bleed is very high even with respect to the ticagrelor as well as prasugrel. Where it is used in case of high risk patient, in case of acute coronary syndrome, as a prophylactic you can administer a ticagrelor. Adverse effect profile, again there is increased risk of bleeding associated with dizziness, shortness of breath, tightness in the chest and irregular pulses. Next, irregular pulse. Next, coming to the glycoprotein 2B3A inhibitors. Under this we have abciximab, eptifibatide and tirofiban. So which is a newer class of drugs, and they are the potent platelet aggregation inhibitors. Basically they inhibit the platelet aggregation. How? They block the GP2B3A, which is a fibrinogen receptor on the activated platelets. On the activated platelet, these GP2B3A receptors are responsible for combining with the other activated platelet. So platelet is there, here is the activated platelet. How it is activated? By activation of the GP2B3A receptors. Once it gets activated, what happens? It will combine with the another platelets. So thereby it goes on multiplying and it goes on accumulating the platelet, and platelets will aggregate together, form a thrombus. So mechanism, as you know that GP2B3A adhesive receptor, which is an integrin on the platelet surface, and it is for what? For fibrinogen. Whenever the fibrinogen combines with the GP2B3A receptor, it activates the platelets. So fibrin combines to this receptor and activate the platelets. So whenever you inhibit this, fibrinogen cannot activate the platelet. So agonists are collagen, thrombin, thromboxane A2, ADP or all the platelet activators. So they induce platelet aggregation. So these apixaban, iptafibatide will going to inhibit or reverse this activity by blocking the receptors, blocking the GP2B3A receptors. So where it is used only in the patients with acute coronary syndrome with unstable angina as a cover for the percutaneous intervention or for coronary artery bypass grafting. So adverse effect profile, again the bleeding risk is there, thrombocytopenia risk is there. And coming to the apixaban, apixaban is a non-antigenic, relatively non-specific in nature mechanism. It is a Fab fragment of chimeral monoclonal antibody against the GP2B3A protein. So the advantage is there is a marked reduction in the restenosis, subsequent MI is reduced and the death risk is reduced. And also there is a reduction in the ischemic event as well. So where this apixaban is used, they are given along with the aspirin along as with the heparin also during the percutaneous intervention, along with clopidogrel for the PCI in case of high risk acute coronary syndrome patient. So basically it is used in unstable angina adjuvant to coronary thrombolysis and PCI with stent placement. The disadvantages, this drug is very expensive in nature. Again, adverse effect profile is same: hemorrhage, bleeding, thrombocytopenia, constipation and ileus, and this apixaban A4A, it can increase the risk of arrhythmias as well. So hemorrhage risk can be reduced by concomitant use of heparin, and once the thrombocytopenia occurs, apixaban, since it is a monoclonal antibody, it should not be used for a second time because already our memory cells would have occurred there is a generation of the antibody which will going to again inhibit the activity of the apixaban if it is taken for a second time. So next we have a iptafibatide. The mechanism is similar, which is a synthetic cyclic peptide, block GP2B3A receptor on the activated platelets. Platelet inhibition reverses in shorter time, that is 6 to 10 hours, and T off is around 2.5 hours longer than apixaban. Why it is quicker? Because it quickly dissociates from the receptors. Where it is used, unstable angina, PCI, adverse effect the same, bleeding and thrombocytopenia. It is used through IV infusion. So it can also be used along with the aspirin and heparin concomitantly. Next, coming to moving on to the tirofiban, which is a non-peptide and it's a specific antagonist of the GP2B3A receptors. The T off is 2 hours. Again, it quickly dissociates from the receptor and used in unstable angina and PCI. Adverse effects remain same, bleeding and thrombocytopenia. Next, coming to the cilostazol. Cilostazol is a phosphodiesterase 3 inhibitor. And what are the other phosphodiesterase inhibitor? We have enambrinol, milrinol, etc. So mechanism remains same. They inhibit the phosphodiesterase activity, thereby they increase the cyclic AMP levels by decreasing the cyclic AMP hydrolysis. They increase the cyclic AMP in the platelet as well as the vascular smooth muscles, leading to anti-aggregatory action and vasodilation respectively. So pharmacokinetic action, they are metabolized by the 3A4 as well as 2C19 microsomal enzymes. T off is around 12 hours. Used in case of intermittent claudication. Cilostazol, very important indication. They are used in intermittent claudication with no rest pain or heart failure, for stroke prevention, cardiac stress testing and prevention of coronary stent restenosis. Adverse effects, again they can increase the bleeding also. Apart from that, they can cause nausea, headache, dizziness, facial flushing, hypotension, abdominal pain. There can be increased risk of ventricular ectopic and non-sustained ventricular tachycardias. So that's why they are contraindicated or not to use in case of heart failure, pain at rest and with tissue necrosis. So coming to the newer drug, that is Vorapaxar, is a reversible antagonist of protease activated receptor, or it is an antagonist of PAR1 receptor expressed on platelets. It has got long half-life and also it irreversibly inhibits the thrombin induced and thrombin receptor agonist peptide induced platelet aggregation as well. So previously what we said, it's a reversible PAR1 antagonist, and also it is an irreversible inhibitor of thrombin induced thrombin receptor agonist peptide induced platelet aggregation. Again metabolized by 3A4. And coming to the end of this antiplatelet drugs, so in general, what are the uses of antiplatelet drugs? They are used in coronary artery disease, unstable angina, STEMI, NSTEMI, cerebrovascular diseases like the transient ischemic attacks, prosthetic heart valve, atriovenations, venous thromboembolism, along with the heparin in case of peripheral vascular disease. And main adverse effect associated with antiplatelet drug will be your bleeding. And again, you need to remember these antiplatelet drugs. So we have covered these antiplatelet drug mechanism, their adverse effects, and the uses and contraindication as well. So this is the summary. We have covered the classification, mechanism, clinical indication, and adverse effects and contraindications. Thank you.